Signs of stroke. Knowing the signs of a stroke is the first step in stroke prevention. A stroke, sometimes called a brain attack, occurs when blood flow to an area in the brain is cut off. The brain cells, deprived of the oxygen and glucose needed to survive, die. If a stroke is not caught early, permanent brain damage or death can result. The symptoms start abruptly and may slowly worsen over a few hours or days. Symptoms always last more than 24 hours and depend on which cerebral blood vessel and which part of the brain are affected. What are the symptoms of stroke? The most common symptoms of a stroke are weakness or numbness or paralysis of the face, arm, or leg on one side of the body, hemiparesis or hemiplegia, loss of vision or dimming, like a curtain falling, in one or both eyes, double vision, diplopia, drooping of one upper eyelid, ptosis, with small pupil and lack of sweating on that side of the face, Horner's syndrome, loss of speech, difficulty talking, or understanding what others are saying, sudden, severe headache with no known cause, loss of balance or unstable walking, usually combined with another symptom, sudden severe giddiness, nausea and vomiting, confusion, coma. Why does a stroke affect different parts of the body? Nerve cells in the brain tissue communicate with other cells to control functions including memory, speech and movement. When a stroke occurs, nerve cells in the brain tissue become injured. As a result of this injury, nerve cells cannot communicate with other cells, and functions are impaired. If a stroke occurs on the right side of the brain, the left side of the body is affected, and vice versa. Types of stroke. The type of stroke you have affects your treatment and recovery. The three main types of stroke are 1. Ischemic stroke. 2. Hemorrhagic stroke. 3. Transient ischemic attack, a warning or mini stroke. Ischemic stroke. Most strokes, 87%, are ischemic strokes. An ischemic stroke happens when blood flow through the artery that supplies oxygen-rich blood to the brain becomes blocked. Blood clots often cause the blockages that lead to ischemic strokes. Hemorrhagic stroke. A hemorrhagic stroke happens when an artery in the brain leaks blood or ruptures, breaks open. The leaked blood puts too much pressure on brain cells, which damages them. High blood pressure and aneurysms, balloon-like bulges in an artery that can stretch and burst, are examples of conditions that can cause a hemorrhagic stroke. There are two types of hemorrhagic strokes. Intracerebral hemorrhage is the most common type of hemorrhagic stroke. It occurs when an artery in the brain bursts, flooding the surrounding tissue with blood. Subarachnoid hemorrhage. Subarachnoid hemorrhage is a less common type of hemorrhagic stroke. It refers to bleeding in the area between the brain and the thin tissues that cover it. Transient ischemic attack, TIA. A transient ischemic attack, TIA, is sometimes called a mini-stroke. It is different from the major types of stroke because blood flow to the brain is blocked for only a short time, usually no more than 5 minutes. It is important to know that a TIA is a warning sign of a future stroke. A TIA is a medical emergency, just like a major stroke. Strokes and TIAs require emergency care. There is no way to know in the beginning whether symptoms are from a TIA or from a major type of stroke. Like ischemic strokes, blood clots often cause TIAs. More than a third of people who have a TIA and don't get treatment have a major stroke within 1 year. As many as 10% to 15% of people will have a major stroke within 3 months of a TIA. 2. Recognizing and treating TIAs can lower the risk of a major stroke. If you have a TIA, your healthcare team can find the cause and take steps to prevent a major stroke. Is it possible to prevent a stroke? Up to 50% of all strokes are preventable. Many risk factors can be controlled before they cause problems. Controllable risk factors for stroke: high blood pressure, atrial fibrillation, uncontrolled diabetes, high cholesterol, smoking, excessive alcohol intake, obesity, carotid or coronary artery disease. Uncontrollable risk factors for stroke: age above 65, gender, men have more strokes, but women have deadlier strokes, race, African Americans are at increased risk, family history of stroke. Causes of stroke: About 80% of the strokes are due to a blood clot blocking an artery in the brain, ischemic, while the remainder are due to bleeding into brain tissue from a ruptured blood vessel, hemorrhagic. Either event causes the death of an area of brain tissue, cerebral infarct, and the permanent loss of cells. The underlying cause of a stroke is usually atherosclerosis, hardening of the arteries. In atherosclerosis, fatty plaques and scar tissue form in artery walls, restricting the blood flow. Blood clots, thrombi, often from the plaques, further blocking the arteries. Fragments of clot may detach and circulate in the bloodstream, emboli. If a fragment lodges in a smaller blood vessel in the brain, it may block and cause a stroke. You can treat some conditions that make you more likely to have a stroke. Other things that put you at risk can't be changed. High blood pressure. Your doctor may call it hypertension. It's the biggest cause of strokes. If your blood pressure is typically 130/80 or higher, your doctor will discuss treatments with you. Tobacco, smoking or chewing it raises your odds of a stroke. Nicotine makes your blood pressure go up. Cigarette smoke causes a fatty buildup in your main neck artery. You can also have clogged arteries from fatty deposits. Diabetes, people who have it often have high blood pressure and are more likely to be overweight. Both raise the chance of a stroke. Diabetes damages your blood vessels, which makes a stroke more likely. If you have a stroke when your blood sugar levels are high, the injury to your brain is greater. Weight and exercise, your chances of a stroke may go up if you're overweight. You can lower your odds by working out every day. Take a brisk 30-minute walk, or do muscle strengthening exercises like push-ups and working with weights. Medications, some medicines can raise your chances of stroke. For instance, blood-thinning drugs, which doctors suggest to prevent blood clots, can sometimes make a stroke more likely through bleeding. Studies have linked hormone therapy, used for menopause symptoms like hot flashes, with a higher risk of strokes. And low-dose estrogen in birth control pills may also make your odds go up. Age, anyone could have a stroke, even babies in the womb. Generally, your chances go up as you get older. They double every decade after age 55. Family, strokes can run in families. You and your relatives may share a tendency to get high blood pressure or diabetes. Some strokes can be brought on by a genetic disorder that blocks blood flow to the brain. Gender, women are slightly less likely to have a stroke than men of the same age. But women have strokes at a later age, which make them less likely to recover and more likely to die as a result. Race, strokes affect African Americans and non-white Hispanic Americans much more often than any other group in the U.S. Sickle cell disease, a genetic condition that can narrow arteries and interrupt blood flow, is also more common in these groups. It is also common in people whose families came from the Mediterranean, the Middle East, or Asia. Strokes are usually diagnosed by doing physical tests and studying images of the brain produced during a scan. When you first arrive at hospital with a suspected stroke, the doctor will want to find out as much as they can about your symptoms. A number of tests can be done to confirm the diagnosis and determine the cause of the stroke. This may include a blood test to find out your cholesterol and blood sugar level, checking your pulse for an irregular heartbeat, taking a blood pressure measurement, brain scans. Brain scan. Even if the physical symptoms of a stroke are obvious, brain scans should also be done to determine if the stroke has been caused by a blocked artery, ischemic stroke, or burst blood vessel, hemorrhagic stroke. Which part of the brain has been affected, how severe the stroke is. Everyone with suspected stroke should have a brain scan within 1 hour of arriving at hospital. An early brain scan is especially important for people who might benefit from medicine to clear blood clots, thrombolysis, such as alteplase or early anticoagulant treatment. Are already taking anticoagulant treatments, have a lower level of consciousness. This is why a stroke is a medical emergency and you should call 999 when a stroke is suspected. There's no time to wait for a GP appointment. The two main types of scan used to assess the brain in people who have had a suspected stroke are a CT scan and MRI scan. A CT scan is like an X-ray, but uses multiple images to build up a more detailed three-dimensional picture of your brain to help your doctor identify any problem areas. During the scan, you may be given an injection of a special dye into one of the veins in your arm to help improve the clarity of the CT image and look at the blood vessels that supply the brain. If it's suspected you're experiencing a stroke, a CT scan is usually able to show whether you have had an ischemic stroke or a hemorrhagic stroke. It's generally quicker than an MRI scan and can mean you're able to receive appropriate treatment sooner. An MRI scan uses a strong magnetic field and radio waves to produce a detailed picture of the inside of your body. It's usually used in people with complex symptoms, where the extent or location of the damage is unknown. It's also used in people who have recovered from a transient ischemic attack, TIA. This type of scan shows brain tissue in greater detail, allowing smaller, or more unusually located, areas affected by a stroke to be identified. As with a CT scan, special dye can be used to improve MRI scan image. A swallow test is essential for anybody who has had a stroke, as the ability to swallow is often affected soon after having a stroke. When a person cannot swallow properly, there's a risk that food and drink may get into the windpipe and lungs, which can lead to chest infections such as pneumonia. This is called aspiration. The test is simple. The person is given a few teaspoons of water to drink. If they can swallow this without choking and coughing, they'll be asked to swallow half a glass of water. If they have any difficulty swallowing, they'll be referred to a speech and language therapist for a more detailed assessment. They usually will not be allowed to eat or drink normally until they have seen the therapist. Fluids or nutrients may need to be given directly into a vein in the arm, intravenously, or through a tube inserted into their stomach via their nose. Heart and blood vessel tests. Further tests on the heart and blood vessels might be done later to confirm what caused your stroke. Some of the tests that may be performed are described below. Carotid ultrasound. A carotid ultrasound scan can help to show if there's narrowing or blockages in the neck arteries leading to your brain. An ultrasound scan involves using a small probe, transducer, to send high-frequency sound waves into your body. Ultrasound. When these sound waves bounce back, they can be used to create an image of the inside of your body. When carotid ultrasonography is needed, it should happen within 48 hours. Echocardiography. An echocardiogram makes images of your heart to check for any problems that could be related to your stroke. This usually involves moving an ultrasound probe across your chest, transthoracic echocardiogram. An alternative type of echocardiogram called transesophageal echocardiography, TOE, may sometimes be used. An ultrasound probe is passed down your gullet, esophagus, usually under sedation. As this allows the probe to be placed directly behind the heart, it produces a clear image of blood clots and other abnormalities that may not be seen with a transthoracic echocardiogram. Effective treatment of stroke can prevent long-term disability and save lives. The specific treatments recommended depend on whether a stroke is caused by a blood clot blocking the flow of blood to the brain, ischemic stroke, bleeding in or around the brain, hemorrhagic stroke. Treatment usually involves taking one or more different medicines, although some people may also need surgery. Treating ischemic strokes. If you have had an ischemic stroke, a combination of medicines to treat the condition and prevent it happening again is usually recommended. Some of these medicines need to be taken immediately and only for a short time, while others may only be started once the stroke has been treated and may need to be taken long-term. Thrombolysis, clot-buster medicine. Ischemic strokes can often be treated using injections of a medicine called alteplase, which dissolves blood clots and restores blood flow to the brain. This use of clot-busting medicine is known as thrombolysis. Alteplase is most effective if started as soon as possible after the stroke occurs, and certainly within 4.5 hours. It's not generally recommended if more than 4.5 hours have passed, as it's not clear how beneficial it is when used after this time. Before alteplase can be used, it's very important that a brain scan is done to confirm a diagnosis of an ischemic stroke. This is because the medicine can make the bleeding that occurs in hemorrhagic strokes worse. Thrombectomy. A small number of severe ischemic strokes can be treated by an emergency procedure called a thrombectomy. This removes blood clots and helps restore blood flow to the brain. Thrombectomy is only effective at treating ischemic strokes caused by a blood clot in a large artery in the brain. It's most effective when started as soon as possible after a stroke. The procedure involves inserting a catheter into an artery, often in the groin. A small device is passed through the catheter into the artery in the brain. The blood clot can then be removed using the device, or through suction. The procedure. The procedure can be done under local or general anesthetic. Aspirin and other antiplatelets. Most people will be offered a regular dose of aspirin. As well as being a painkiller, aspirin is an antiplatelet, which reduces the chances of another clot forming. Other antiplatelet medicines may be used, such as clopidogrel and dipyridamole. Anticoagulants. Some people may be offered an anticoagulant to help reduce their risk of developing new blood clots in the future. Anticoagulants prevent blood clots by changing the chemical composition of the blood in a way that prevents clots from forming. Warfarin, apixaban, dabigatran, edoxaban and rivaroxaban are examples of anticoagulants for long-term use. There are also a number of anticoagulants called heparins, which can only be given by injection and are used short-term. Anticoagulants may be offered if you have a type of irregular heartbeat called atrial fibrillation, which can cause blood clots. Have a history of blood clots. Develop a blood clot in your leg veins, deep vein thrombosis, DVT, because a stroke has left you unable to move one of your legs. Blood pressure medicines. If your blood pressure is too high, you may be offered medicines to lower it. Medicines that are commonly used include thiazide diuretics, angiotensin-converting enzyme, ACE, inhibitors, calcium channel blockers, beta blockers, alpha blockers. Statins. If the level of cholesterol in your blood is too high, you'll be advised to take a medicine known as a statin. Statins reduce the level of cholesterol in your blood by blocking a chemical, enzyme, in the liver that produces cholesterol. You may be offered a statin even if your cholesterol level is not particularly high, as it may help reduce your risk of stroke whatever your cholesterol level is. Carotid endarterectomy. Some ischemic strokes are caused by narrowing of an artery in the neck called the carotid artery, which carries blood to the brain. The narrowing, known as carotid stenosis, is caused by a buildup of fatty plaques. If the carotid stenosis is very severe, surgery may be used to unblock the artery. This is called a carotid endarterectomy. It involves the surgeon making a cut, incision, in your neck to open up the carotid artery and remove the fatty deposits. Treating hemorrhagic strokes. As with ischemic strokes, some people who have had a hemorrhagic stroke will also be offered medicine to lower their blood pressure and prevent further strokes. If you were taking anticoagulants before you had your stroke, you may also need treatment to reverse the effects of the medicine and reduce your risk of further bleeding. Surgery. Occasionally, emergency surgery may be needed to remove any blood from the brain and repair any burst blood vessels. This is usually done using a surgical procedure known as a craniotomy. During a craniotomy, a section of the skull is removed to allow the surgeon access to the source of the bleeding. The surgeon will repair any damaged blood vessels and ensure there are no blood clots present that may restrict the blood flow to the brain. Metal plate. After the bleeding has been stopped, the piece of bone removed from the skull is replaced, often by an artificial metal plate. Surgery for hydrocephalus. Surgery can also be done to treat a complication of hemorrhagic strokes called hydrocephalus. This is where damage resulting from a stroke causes cerebrospinal fluid to build up in the cavities, ventricles, of the brain. It causes symptoms such as headaches, sickness, drowsiness, vomiting and loss of balance. Hydrocephalus can be treated by putting a tube, called a shunt, into the brain to allow the fluid to drain. Supportive treatments. You may need further short-term treatment to help manage some of the problems that can affect people who have had a stroke. For example, you may require a feeding tube inserted into your stomach through your nose, nasogastric tube, to provide nutrition if you have difficulty swallowing, dysphagia. Nutritional supplements if you're malnourished. Fluids given directly into a vein, intravenously, if you're at risk of dehydration. Oxygen through a nasal tube or face mask if you have low levels of oxygen in your blood. Compression stockings to prevent blood clots in the legs, DVT. The injury to the brain caused by a stroke can lead to widespread and long-lasting problems. Although some people may recover quickly, many people who have a stroke need long-term support to help them regain as much independence as possible. This process of rehabilitation depends on the symptoms and their severity. It often starts in hospital and continues at home or at a local clinic in your community. A team of different specialists may help with your rehabilitation, including physiotherapists, psychologists, occupational therapists, speech and language therapists, dietitians, and specialist nurses and doctors. You'll be encouraged to actively participate in the rehabilitation process and work with your care team to set goals you want to achieve during your recovery. The different treatment and rehabilitation methods for some of the common problems caused by strokes are outlined below. Two of the most common psychological problems that can affect people after a stroke are depression. Many people experience intense bouts of crying, feel hopeless and withdraw from social activities. Anxiety, where people experience general feelings of fear and anxiety, sometimes with moments of intense, uncontrolled feelings of anxiety attacks. Feelings of anger, frustration and bewilderment are also common. You'll receive a psychological assessment from a member of your healthcare team soon after your stroke to check if you're experiencing any emotional problems. Advice should be given to help you deal with the psychological impact of stroke. This includes the impact on relationships with other family members and any sexual relationship. There should also be a regular review of any problems of depression and anxiety, and psychological and emotional symptoms generally. Psychiatrist. These problems may settle down over time, but if they're severe or last a long time, GPs can refer people for expert healthcare from a psychiatrist or clinical psychologist. For some people, medicines and psychological therapies, such as counseling or cognitive behavioral therapy, CBT, may help. CBT is a therapy that aims to change the way you think about things to produce a more positive state of mind. Cognitive impact. Cognitive is a term that refers to the many processes and functions our brain uses to process information. One or more cognitive functions can be disrupted by a stroke, including communication, spatial awareness, having a natural awareness of where your body is in relation to your immediate environment, memory, concentration. Executive function, the ability to plan, solve problems and reason about situations. Praxis, the ability to carry out skilled physical activities, such as getting dressed or making a cup of tea. As part of your treatment, each one of your cognitive functions will be assessed, and a treatment and rehabilitation plan will be created. You can be taught a wide range of techniques that can help you relearn disrupted cognitive functions, such as recovering your communication skills through speech and language therapy. There are many ways to compensate for any loss of cognitive function, such as using memory aids, diaries and routines to help plan daily tasks. Most cognitive functions will return with time and rehabilitation, but you may find they do not return to the way they were before. The damage a stroke causes to your brain also increases the risk of developing vascular dementia. This may happen immediately after a stroke or may develop sometime after the stroke happened. Movement problems. Strokes can cause weakness or paralysis on one side of the body, and can result in problems with coordination and balance. Many people also experience extreme tiredness, fatigue, in the first few weeks after a stroke, and may also have difficulty sleeping, making them even more tired. As part of your rehabilitation, you should be seen by a physiotherapist, who'll assess the extent of any physical disability before creating a treatment plan. Physiotherapy will often involve several sessions a week, focusing on areas such as exercises to improve your muscle strength and overcome any walking difficulties. The physiotherapist will work with you by setting goals. At first, these may be simple goals, such as picking up an object. As your condition improves, more demanding long-term goals, such as standing or walking, will be set. A care worker or carer, such as a member of your family, will be encouraged to become involved in your physiotherapy. The physiotherapist can teach you both simple exercises you can do at home. If you have problems with movement and certain activities, such as getting washed and dressed, you may also receive help from an occupational therapist. They can find ways to manage any difficulties. Occupational therapy may involve adapting your home or using equipment to make everyday activities easier, and finding alternative ways of achieving tasks you have problems with. Communication problems. After having a stroke, many people experience problems with speaking and understanding, as well as reading and writing. If the parts of the brain responsible for language are damaged, this is called aphasia, or dysphagia. If there's weakness in the muscles involved in speech as a result of brain damage, this is known as dysarthria. You should see a speech and language therapist as soon as possible for an assessment and to start therapy to help you with your communication. Exercise. This may involve exercises to improve your control over your speech muscles. Using communication aids, such as letter charts and electronic aids. Using alternative methods of communication, such as gestures or writing. Swallowing problems. The damage caused by a stroke can interrupt your normal swallowing reflex, making it possible for small particles of food to enter your windpipe. Problems with swallowing is known as dysphagia. Dysphagia can lead to lung damage, which can trigger a lung infection, pneumonia. You may need to be fed using a feeding tube during the initial phases of your recovery to prevent any complications from dysphagia. The tube is usually put into your nose and passed into your stomach, nasogastric tube. Or it may be directly connected to your stomach in a small operation done using local anesthetic, percutaneous endoscopic gastrostomy, or PEG. In the long term, you'll usually see a speech and language therapist several times a week to manage your swallowing problems. Treatment may involve tips to make swallowing easier, such as taking smaller bites of food and advice on posture, and exercises to improve control of the muscles involved in swallowing. Visual problems. Stroke can sometimes damage the parts of the brain that receive, process and interpret information sent by the eyes. This can result in losing half the field of vision, for example, only being able to see the left or right side of what's in front of you. Stroke can also affect the control of the eye muscles. This can cause double vision. If you have problems with your vision after a stroke, you'll be referred to an eye specialist called an orthoptist, who can assess your vision and suggest possible treatments. For example, if you have lost part of your field of vision, you may be offered eye movement therapy. This involves exercises to help you look to the side with the reduced vision. You may also be given advice about how to perform tasks that can be difficult if your vision is reduced on one side, such as getting dressed. Bladder and bowel control. Some strokes damage the part of the brain that controls the bladder and bowel. This can result in urinary incontinence and difficulty with bowel control. Some people may regain bladder and bowel control quite quickly, but if you still have problems after leaving hospital, ask for advice if you have a problem, as there are lots of treatments that can help. These include bladder retraining exercises, medicines, pelvic floor exercises, using incontinence products. Sex after a stroke. Having sex will not put you at higher risk of having another stroke. There's no guarantee you will not have another stroke, but there's no reason why it should happen while you're having sex. Even if you have been left with a severe disability, you can experiment with different positions and find new ways of being intimate with your partner. Be aware that some medicines can reduce your sex drive, libido, so make sure your doctor knows if you have a problem, as there may be other medicines that can help. Some men may experience erectile dysfunction after a stroke. Rehabilitation. Speak to your GP or your rehabilitation team if this is the case, as there are several treatments that may help. Driving after a stroke. If you have had a stroke or TIA, you cannot drive for 1 month. Whether you can return to driving depends on what long-term disabilities you may have and the type of vehicle you drive. It's often not physical problems that can make driving dangerous, but problems with concentration, vision, reaction time and awareness that can develop after a stroke. Your GP can advise you on whether you can start driving again 1 month after your stroke, or whether you need further assessment at a mobility center. Preventing further strokes. If you have had a stroke, your chances of having another one are significantly increased. You'll usually require long-term treatment with medicines that improve the risk factors for your stroke. For example, medicine to help lower your high blood pressure, anticoagulants or antiplatelets to reduce your risk of blood clots, statins to lower your cholesterol levels. You'll also be encouraged to make lifestyle changes to improve your general health and lower your stroke risk, such as eating a healthy diet, exercising regularly, stopping smoking if you smoke, drinking alcohol within the recommended limits, caring for someone who's had a stroke. There are many ways you can provide support to a friend or relative who's had a stroke. These include helping them do their physiotherapy exercises in between their sessions with the physiotherapist, providing emotional support and reassurance that their condition will improve with time, helping to motivate them to reach their long-term goals, adapting to any needs they may have, such as speaking slowly if they have communication problems. Caring for someone after they've had a stroke can be a frustrating and lonely experience. The advice outlined below may help. Be prepared for changed behavior. Someone who's had a stroke can often seem as though they have had a change in personality and appear to act irrationally at times. This is the result of the psychological and cognitive impact of a stroke. They may become angry or resentful towards you. Upsetting as it may be, try not to take it personally. It's important to remember they'll often start to return to their old self as their rehabilitation and recovery progresses. Try to remain patient and positive. Rehabilitation can be a slow and frustrating process, and there will be times when it seems as though little progress has been made. Encouraging and praising any progress, no matter how small it may appear, can help motivate someone who's had a stroke to achieve their long-term goals. Make time for yourself. If you're caring for someone who's had a stroke, it's important not to neglect your own physical and psychological well-being. Socializing with friends or pursuing leisure interests will help you cope better with the situation.